combinations and the targeted therapies in the government setting, which is the ML4Ls and the ROS, specifically the crizotinibs and so on? Because
Sir,
Osimertinib,
so far
I can understand. Yeah.
It is difficult to talk about that because or research on that based on adjuvant settings. But ROS1 and ALK mutations are fairly uncommon. 1%, 2% of ROS1 chance, 5% for an ALK mutation. So it is difficult to accumulate as many patients in a randomized controlled trial to show the benefit of ROS1 or ALK mutation. EGFR is about 30 to 35%. So it is easier to do. So ADAURA study was still conceptually feasible, but to do a study for ROS1 and ALK mutation will be difficult task because to accumulate as many patients in early stage lung cancer, then they are resectable and then they are randomized to crizotinib versus no crizotinib. I think such a study would be very difficult to conceptualize. Yet, I think one can take a corollary from the studies and from what we understand of crizotinib in late stage lung cancer and offer them crizotinib. As I just explained that we had a gynecologist who was recently detected to have a stage 3 lung cancer, underwent surgery, and now we are planning to give her crizotinib for about 3 years. We have discussed with her that there is no data. We have discussed the ADAURA trial data with her. She's a doctor herself. She says, I want crizotinib.
Right. And my follow-on question, just a quick one, is now we are talking about the biopsies, usually, which will help us get the tissue or, for the mutation analysis. So what is the advice? Because we normally see that the patients undergo the surgery, and if the targeted therapy becomes incidental, approved by the government of India or for patients, whatever, they don't have a block. And if they have a block, which is an FFP block, the amount of biopsy in lung cancers in early stages especially would be very small. So where would you advise it to be used, for the immunohistochemistry or for the mutation analysis, as per your experience? Because we see, we cannot revive a lot of DNA from there. We have a good genetic testing.
So, sir, if there is hardly any confusion on diagnosis, say it is clear-cut lung cancer, there's no confusion. So I think we can forego the ISC and do only mutational analysis and not waste the tissue, because there's hardly any substitute for a mutational analysis. In case there is a diagnostic dilemma, so you have to subject the biopsy through immunohistochemistry and then do the mutation analysis.
Right.
So I think this is how you would triage the block. One option of doing mutational analysis is also liquid biopsy, that is circulating tumor DNA. That can also be subjected to mutation analysis, but it is fraught with its own limitations, which is in about 40% patients, you may not detect a mutation where it would be present in the main tissue or the tumor block.
Right. And thank you very much. Very well said. So as a medical oncologist into a large setting hospital, would you recommend low density CT to be coming up as a screening technique for at least the higher risk patients?
Sorry, I didn't get that.
The low density CT you were talking about for the early stage cancers, would you?
It's not into practice. It's not into practice.
No, from your experience, would you love to have it as a?
I would love to have it. I need to know the smoking history. You know that patients don't give their smoking history. आप किसी lung cancer patient को बोलो कि cigarette पीते थे, कि छोड़ दी. They will never say कि कितने दिन तक पी.
Right.
And they will shy away from that because that's the guilt, that inner guilt they don't allow. But in case there is a well-informed person who says, yes, I've been smoking and I've got a 20-pack year history, I don't shy away from offering them low-dose helical CTs.
All right, fair enough. Thank you very much.
Right, sir. Thank you.
Dr. Manish.